Hi, thanks everyone. Thanks Namu, and thanks everyone for joining us this evening. I've been looking forward to this for a few weeks actually. It's quite an exciting lineup of speakers, and I hope we're all going to learn something. I'll just do a very brief introduction, and then I'll let the clever people who've come to talk to us crack on with what they've got to say. Now, as you probably remember from the flyer, we're here to talk about genomics in health and disease. Addenbrooke's is not just your local district general hospital, it's also a major hub for scientific innovation and research in medicine. So the things we do here have national impact, and it gives us a great opportunity to showcase some of that. The objectives here are to help you understand the importance of a genome, raise awareness of the role of genomics in healthcare and how it can influence treatment choice and outcomes, and highlight the importance of scientists within healthcare and the NHS. We've got a couple of really good scientists joining us. First, I'll introduce Patrick. Patrick Tarpey is the East Genomics Laboratory Hub Cancer Lead Scientist. He's trained as a clinician scientist actually in London and Cambridge before he moved to the Sanger to pursue research. And at the Sanger Institute, he worked on the cancer genome group under Mike Stratton, utilising genomic data to explore somatically acquired variation, and this led to the discovery of multiple novel cancer genes. Patrick returned to clinical science at Addenbrooke's to lead analysis of over 100,000 cancer genomes, and he's presently the lead scientist for the solid cancer within the Genomic Laboratory Hub. Patrick leads a team of scientists. He utilises genomic data to evolve cancer services and enhance opportunities for patients across the Eastern region. So I'm really looking forward to what Patrick has to say. Our second speaker is Kate Downs, another clinician scientist. Kate spent her career working on human disease genetics, first again at the Sanger Institute and then at the University of Cambridge. Now she's come to the NHS from the university, and she's a clinical scientist working in the Cambridge Genomics Laboratory. And in fact, Kate's the lead scientist for rare disease. She's leading the rare disease and inherited disease screening strategy for patients across the East. And again, she's going to have some really interesting things to say, I'm sure. Once you've heard from these two, we're going to move into a Q&A session, and we're going to be supported there by a couple of our clinician leads. We've got Richard Sanford, who's the East Genomic Laboratory Hub clinical lead for rare disease. And we've got Gary Doherty, who's the East Genomic Laboratory Hub clinical lead for cancer. So very much looking forward to the Q&A later on. Now, you'll probably want to know that you are very free to ask questions. You'll see at the bottom of your screen down there, there's a Q&A box that will let you pop a question in, and we'll get on to answering those in the Q&A session towards the end. And if you do think of further questions during the Q&A, feel free to pop them in there. And the same goes for those of you on Facebook, and Namu will be picking up questions put in through the Facebook chat. Just a final couple of little bits of housekeeping. For those of you who aren't members of the Foundation Trust yet, you can sign up via our website. Just search for CUH or go to www.cuh.nhs.uk. I think that's all I really wanted to get across for this introduction session. Namu, anything I've left out? Anything you'd like me to cover?
No, it sounds all good to me, Will. Thank you.
Brilliant. Okay, well, without too much further ado in that case, I'll hand over to Kate Downs, who's our rare disease lead scientist. I'll take it away, Kate.
Thank you very much. Well, can everybody hear me? Yeah. Okay. So so thank you, Will. You've given us a great introduction. So I'm just going to give us a quick, brief introduction about genomics and genomics in the NHS, and then I'm going to pass over to Patrick, who's going to talk about genomics and cancer, and then you're going to come back to me to talk about genomics and rare disease, and then of course, as Will said, we have Dick and Gary who are joining us to help us answer some of your questions. So I guess I've been tasked to kind of set the scene and to try and get across what is genomics and what is genomics in the NHS. So for those of you who haven't done biology recently, you need to cast your mind back to your A-levels or O-levels or GCSEs, when you were learning about humans and the fact that humans were made up of a bunch of cells, and in those cells was a nucleus, and in that nucleus is the DNA that is responsible for building that whole human body. And the DNA in our nucleuses is packed up into chromosomes, and you can think about these chromosomes like, I think, maybe books, maybe recipe books. That's a good analogy. So the chromosomes are recipe books in this nucleus, which is this recipe book library. And if you unravel these chromosomes, you can see the DNA strands, this double helix, and if you stretch that out even further, you start to see this backbone with these nucleotides, these single letters that form the DNA. So if we think about our chromosomes as the recipe books and maybe the genes as the recipes, there's also lots of bits of DNA that actually don't do much, and maybe they're the pictures that fill those recipe books from celebrities. And these nucleotides, these are the letters of the alphabet that make up our DNA. And so when we're thinking about genomics, we're really thinking about the study of our DNA, of our chromosomes, of our nucleotides, of our genes. So what causes genetic diseases, genomic diseases? And I guess we're going to use a few different terms for this today. So the first term is thinking about genetic changes causing genomic disease. And when I talk about rare diseases, inherited diseases, I'm going to talk about variants. And Patrick's probably going to talk about mutations. But these are all the same things. They're just genetic changes that can cause disease. So these genetic changes can have really huge different implications. So we can have a duplication of a chromosome that can cause a disorder, or we can have a single letter change in a gene that can cause a disease. So there's several things that you need to think about when you're thinking if a genetic change causes a disease, but there's two key things that we often think about. So the first key thing is, what does that genetic change do? And so the bits of DNA that we understand the most, the genes in our body, they get photocopied. So that recipe gets photocopied and it gets taken to the protein kitchen, and a protein is made from that recipe. And a DNA change that disrupts either the photocopying or the kitchen instructions, or that mean that protein isn't made properly, or there's not enough of it made, or it doesn't do the job properly, or doesn't go to where it should do properly in the cell. Each of those different types of circumstances could cause a genetic disease. The other key thing is, where in the body is this cell that has that genetic change? So if that cell is one of our egg or sperm cells, then those genetic changes could be inherited, and the child of that person would, every single cell in their body would have that genetic change. But of course, if there's a genetic change perhaps in a lung cell or a different type of cell that's not involved, that's not a sperm or an egg cell, then that genetic change may do nothing, but it also may cause cancer, and that's what Patrick's going to talk about tonight. So I just want to tell you a little bit about some of the major changes that have happened in how we as a community are delivering genomics in the NHS. So over the last 5 years, we've introduced this entity called the Genomic Medicine Service for NHS England. And these are the aims, and I'm not going to read them all out, but one of the key aims is that we're going to provide a service that is consistent and equitable for all patients. So previously, depending on where you lived, whether you lived next to a big teaching hospital or whether you lived in the middle of Cumbria, you might have had access to different types of genetic tests, different expertise. And the whole point of this genomic medicine service is to provide this equity across the country for all patients. We're going to operate to common national standards. And I'm going to talk a little bit about a single national test directory. So we have a catalogue of tests that our clinicians can order from, and those are delivered according to standards that are set across the NHS. So just to kind of give you a flavour of how we fit in Cambridge to this genomic medicine service. So our Cambridge University Hospital's Genomics Laboratory is sitting here in the East GLH region, and we are the lead lab for the East Genomics Laboratory Hub here. And you can see we serve this turquoise region that goes all the way from Colchester down in the southeast to Nottingham, Leicester, up to Bedford, and across to Lister. So we serve a huge region of about 10 million people. And here you can see that we, as a network with other genomic laboratory hubs around the country, provide this genomic medicine service. So we're really working together to deliver this catalogue of genetic tests, genomic tests for the whole country. So yeah, so just to come back to these national genomic test directories, it's really important. There's one for rare disease, rare and inherited disease, and one for cancer. And patients are going to be tested using the same strategy wherever they live in the country. And I know I've said that twice now, but it's really key to our equity of testing. These test directories are going to be regularly updated, and new tests are curated by experts. And we're centralizing pipelines for some of these technologies. So rather than building separate processes all across the country, some of the processes that we're building in one particular place. So that's it for me for this introduction. I'm going to pass you to Patrick, and I'll talk to you in a minute about rare diseases. So I'll stop sharing, Patrick.
Thanks, Kate. That was a fantastic introduction. Even for someone like me who has done a little bit of biology, it's still very helpful to go back to some of the basics on how it all works as well. Fantastic. So I'll pass on straight over to Patrick, who's going to talk about genomics in health and disease, but in particular in cancer, I believe. So please take it away, Patrick.
Thanks very much, and thanks for the introduction, Kate. So I trust everyone can hear me and see my slides. So what I'd like to do is just give some brief insight into how we apply genomics within the health service to better understand and to offer better treatments for patients with cancer. So just to expand on Kate's background a little bit within the context of cancer, cancers arise when normal cells, so here depicted in blue, grow more quickly than they should, grow and divide and proliferate. And the subsequent mass of clonal cancer cells, here depicted in red, cause problems because they can invade local nearby tissues and ultimately migrate to secondary sites within the body. And it's this metastatic disease that is responsible for most cancer deaths. So what is responsible for the change in this cellular behavior? What makes these cells turn rogue? And as Kate alluded to, the answer lies within the chromosomes and the genes resident within the nucleus of the cell. So somatic mutations, acquired mutations, not inherited mutations, but those acquired during a patient's lifetime, change the function of key genes known as cancer genes. And it's the changes within those genes that confer changes into that cellular behavior that ultimately manifest or can manifest as a cancer. So why do we acquire these somatic mutations? Where do they come from? So I can answer that question by looking at this image here. So what I'm depicting here is the life history of a cell. So when we are conceived, when we're just a fertilized egg, our genomes are pristine and free from any somatic mutations. But even prior to birth, when our cells divide, we can acquire mutations within individual cells. And the reason for that is as our cells divide, they have to copy all those 3 billion base pairs of DNA, and minor infidelities, minor mistakes during that copying process manifest as somatic mutations within our cells. Now, generally, these mutations are inconsequential. They don't have any net effect change the behavior of those cells, because mostly by chance, they'll reside outside of our genes within our genome. So only a small fraction of our genomes codes for genes. Or they may reside within genes, but don't change the behavior of the proteins encoded by those genes. So it's not a problem to acquire somatic mutations generally, but as we age into childhood and adulthood, we can increase the acquisition of somatic mutation in our cells via the exposure of environmental agents such as UV light or tobacco smoke, for example. And exposure to these DNA damaging agents can increase the acquisition of somatic mutations until by chance, one of them will end up disrupting a key gene known as a cancer gene. And when this happens, that might confer a growth advantage in that cell, which may cause an early clonal expansion, so small clones of similarly rogue cells, and additional acquisition of subsequent driving mutations, again in key genes, can change this early clonal expansion into a benign tumor, and ultimately an invasive cancer, and finally a metastatic cancer. So as a scientist, when we look at cancer genomes, we look at cells, or a clone of different cells, which has an amalgamation of lots and lots of somatically acquired mutations, the vast majority being inconsequential, and we call those passenger variants, and a small minority causing those changes that make those cells behave imperfectly, and these are called driver mutations. So we can depict these driver and passenger mutations in a bit more detail by looking at a tiny fraction of a specific gene. So I'm showing now some sequence from a gene called BRAF, which importance in cancer was identified in 2002 in the Sanger Center just down the road, principally in melanoma. So what I'm showing here at the top is the DNA sequence, the 4-letter code within a normal cell. And underneath the DNA sequence is the single letter code of the amino acids encoded by this DNA. So I'm depicting 4 variants, and a somatic variant is a variant, therefore, that is different to our normal cell. So here in our normal, we have a T, and in our cancer, we have an A. So this is a T to A mutation. Similarly, this is a T to C, and this is a C to T, and this is a T to A. So these are what somatic mutations like and what we endeavor to harvest. Now, if we look at these 3 first mutations here, we can see that they don't change the sequence of these letters here. They don't change the amino acid sequence, so they don't change the resultant protein. So these are examples of inconsequential passenger variants. So although they're not responsible for the change of a normal cell into a cancer cell, they can be interesting and insightful because the pattern of passenger mutations is different in different cancer types, depending on the prior exposures of the cells that have been the genesis of those cancers. So for example, if we were looking at a melanoma, where UV light is a carcinogen, a DNA damaging agent, most of the passenger variants are C to T mutations. So this pattern here is what we see in melanomas of these inconsequential passenger variants. This is a different pattern that we see in tobacco and smokers in lung cancers. So in lung cancers, it's mainly C to A mutations which predominate. In some cancers of the breast, which are caused by mutations in a gene called BRCA1 and 2, we see this pattern. And in cancers of the colorectal that is caused by mutations in this gene, we see this pattern. So although these variants are inconsequential, the pattern can be informative, and the patterns can themselves hold clinically valuable information. However, the main variants which we aim to discover and aim to are of most interest clinically are the driver variants, those variants we acquire in our cells that change the behavior of these normal cells. And this is an example of a key mutation within this BRAF gene here. So it's a T2A mutation, just a single base pair substitution, and it changes this valine in the wild type protein to this glutamic acid, this V to E change here. Now, what this gene normally does is sits within a signaling pathway which contributes to the growth and proliferation of a cell. So it helps contribute to telling a cell when to grow and divide. And normally that only happens in a really regulated way when an external factor, a growth factor, binds to a receptor, and then a signaling pathway is initiated in a very controlled way. Now, the net effect of this single mutation change here is to switch this BRAF gene on constantly. So it's constantly signaling via its downstream partner protein and telling the cell to grow in a constitutively active way constantly. So in the subsequent years since this key mutation in this key gene was identified, this provided opportunity for drug companies to develop drugs to turn off this mutated gene. And a drug called vemurafenib was subsequently developed, which blocks the activity of this mutated BRAF protein. And as a consequence, the cells reliant on this mutated cancer gene die, they senesce. So we can evidence what that looks like in real life by looking at this image here. So this is a PET scan. On the left is a patient with a metastatic melanoma. So we can see lots and lots of green and red, which indicates the presence of lots and lots of actively dividing cancer cells utilizing radio-labeled glucose. And on the left is the patient carrying a BRAF mutated melanoma prior to treatment with this new novel targeted drug. And on the right is the same patient 2 weeks after receipt of this targeted therapy. So we can see post utilization of this therapy, most of these metastatic deposits have disappeared. So this gives some insight into the potential and the power of targeted therapy, where a patient's cancer is treated based on the information contained within their tumor, the genetic information, in addition to conventional therapies. So generally, that's an example, a really good example and a sort of cardinal example of a precision therapy where treatment's targeted by specific changes within the tumor. And this type of therapy, allied to the traditional medicines of surgery, chemotherapy, and radiation, give clinicians an additional tool in their arsenal that they can use to treat patients with cancer. So we can explore the potential of genomics in a bit more detail by looking at highly prevalent cancer such as lung cancer. So a key step when a patient presents with a suspected cancer is to establish the diagnosis, because that will inform the appropriate treatment. And from a pathology perspective, i.e. looking down a microscope and looking at the cells and trying to determine what the diagnosis is, there's 4 different types of lung cancer depicted on this slide here. Now, 3 of those 4 come into the category of non-small cell lung cancer. And if we look at the most common forms of non-small cell lung cancer, adenocarcinomas and squamous cell carcinomas, we can see that the application of genomics adds additional resolution and adds lots more information on top of this pathology classification. So for example, in lung adenocarcinomas, all of these mutated genes have been found. So any particular individual adenocarcinoma may have 1 or 2 mutations in these key genes. So for example, KRAS is mutated in 25% of lung adenocarcinomas and EGFR is mutated in 16%. So that's a really valuable molecular classification to add on to the pathology classification of this lung cancer, and it will help inform the clinician with the appropriate treatment. And the reason it does that, because this plethora of information provides clinical opportunity, because many of these mutated cancer genes are good targets for drugs targeted in the same way that I've described for BRAF, targeted against these additional genes within lung cancers. So for example, in EGFR, there's a drug that's available, it's NICE approved within the NHS setting that can be used in the 16% of patients who harbor an EGFR mutation. So many of these patients are available to patients within the NHS. Others are available to clinicians via compassionate access or in the context of clinical trials. But the key message here is that we have an alliance of a really good understanding of the genomics behind lung cancer in this case, but we have that across lots of cancers now. The availability of existing and prospective drugs that can target these mutated cancer genes, and within the NHS, an increasing use of sequencing to enable us to profile every patient's individual tumour so that they can maximise the opportunities via the identification of genes which may be targetable. So I'm going to end by just giving a couple of vignettes of some work that's been performed here at Addenbrooke's, Cambridge. In the first example, I'm going to give a glimpse of some work we've done exploring childhood cancer. So in the study that I allude to, is a pilot study where we looked at the cancers of 36 children. And amidst those 36 children, there were 23 different cancer types, primarily of the brain and central nervous system. So what we did in these cases is we performed the most useful singular informative assay, whole genome sequence. So we sequenced all of the 3 billion base pairs in each of the tumors from these cancers. And we compared those data to what was known via standard routine NHS assays. So if we look at this slide here, what we're showing is the standard of care assays that were available. And these stars indicate the mutations, the somatic mutations, or the open stars, the germline mutations that were known via the deployment of these standard of care assays, immunohistochemistry, FISH, and panel-based NGS testing. Now, when we overlay the effect of whole genome sequencing, this more expansive assay looking at every single base, we can see that we harvest many more additional somatic and a germline mutation to offer potential opportunity in the clinical management of these cases. So we had lots and lots of information above routine standard of care. But did this actually have, what was the impact of all these mutations in these patients? So first, if we consider diagnosis, many of these mutations helped confirm or solidify an existing diagnosis, but about 15% of the cases we were able to refine a diagnosis into a more discrete subtype, or in some cases actually modify an equivocal diagnosis to one which was secure based on the presence of specific mutated cancer genes. So that's valuable information. Additionally, in over 20% of the cases, we were able to derive novel prognostic information, which is also of clinical value, for example, to define the interval of appropriate clinical follow-up. And key are those targeted therapies. So how many therapeutic opportunities were presented with the addition of this whole genome sequencing? And in about 25% of the cases, mostly constrained to those cancers within the CNS, we were able to find mutations which enable a targeted therapy to be actioned if appropriate and if necessary in that patient's treatment. So this pilot of a relatively modest series of 36 cases evidenced for us the clinical utility of whole genome sequencing in the care of childhood cancer. And as a consequence, this is now routine within Addenbrooke's, and any appropriate patient is referred for whole genome sequence to try and extract this useful additional clinical information. I'll just focus on one case just as a vignette case example. This individual here, this boy who's a 10-year-old who presented with a rare kidney tumor at age 10. It was a very difficult diagnosis to secure. The pathologists were in disagreement about what the exact diagnosis was, so it was quite unusual pathology. And it was either a renal cell carcinoma or a Wilms tumor. And it was important to differentiate which, because that informed the appropriate treatment options. So we performed whole genome sequencing in this renal cancer, and we harvested a constellation of mutations which were consistent with the presence of a Wilms tumor, and we excluded the presence of mutations that would have informed the opposite the alternative diagnosis of a renal cell carcinoma. So this was really good useful information and valuable in this patient's case, because it identified the cancer type, which reassured the clinicians of the appropriate therapy to pursue. In this case, it was conventional therapies, so surgery, chemo, and radio were all performed, and now the patient's in complete remission and playing the sports he engaged with prior to becoming ill. A final vignette is of a relatively recent study which has just been set up looking at adult brain cancers. So in this study, which was set up and led by these individuals, Richard Gilwoodson, Richard Mayer, and Gary Doherty, who's on the call, and the aim was to improve to deploy genomics to improve the therapeutic opportunities for patients with adult brain cancers. And the real motivation here was to develop the infrastructure to enable the very efficient deployment of genomics, consequently to extract those variants that we've discussed that inform diagnosis and treatment opportunities, but also to generate a repository of information that feeds into other studies and drives the development of new novel therapies for the value of future patients. So although this is just in its infancy, it's an exemplar of how quickly an expansive assay, a really perfect assay such as a whole genome, can be performed, with the interval from surgery to clinical and scientific discussion at a team meeting of just 10 days. So within these 10 days, we acquire these data. This is what a whole genome sequence looks like in an adult cancer. These depictions are the sorts of variants we see. And this clarity allows us to expedite the analysis and to be able to deliver these mutations probably quicker than some of the standard of care assays that are currently deployed. So what I present here and in the previous cases is a glimpse of the future, really, deploying the most informative, expansive genomic assays, ideally whole genome sequencing, to deliver really maximal information in minimum time, and as a consequence to really advance the outcomes of patients with cancer within our region. So I'm going to leave it there, and I'll stop sharing and hand back to Kate.
Terrific. Thanks very much, Patrick. That was a great run through. And I've thought of, I don't know if anyone listening has any particular questions. I've thought of a few myself, but please don't forget to put them in the Q&A box if you do. And without further ado, I'll hand straight back over to Kate, who's going to talk about the rare diseases side of this service.
Sorry, I couldn't find my unmute. I've got it now. Thank you. Thanks, Patrick. So yeah, I'm going to talk to us about genomics of rare disease. And I'm going to start with a little rare disease introduction. And then this is a sentence that we all say at the beginning of our talks, that rare diseases are not rare. So there are 3.5 million people living in the UK with rare diseases. So even though an individual rare disease is rare, actually the number of people total who have a rare disease is quite large. So this number means that 1 in 17 of us has a rare disease, and actually the vast majority of cases where a new rare disease is identified is in children. So a lot of these rare diseases are congenital, so a baby is born and symptoms start to manifest straight away. And we know that there are 5,000, probably more by now, rare diseases with a genetic cause. And like I say, we're finding genetics is moving really fast, and we're finding new genetic reasons why people have known disorders, and we're finding new genetic disorders as well all the time. So, so our job is to diagnose those genetic disorders. So I'm just kind of going to step a little bit back of what genetic testing looked like a few years ago before the Genomic Test Directory and the Genomic Medicine Service. And for patients, I think genetic testing was a little bit piecemeal. Often stepwise strategies were employed, and sometimes it took years for patients to receive a diagnosis. So I've just put a little cartoon to kind of demonstrate that a patient would see a doctor, a specialist, or a consultant geneticist. They talk about their family history and maybe note the clinical symptoms, and then perhaps some testing would be done, an ECG or some blood tests or some biochemical tests or an MRI scan that would inform on a likely diagnosis. And then because there was lots of different labs across the UK doing lots of different genetic tests and specialising in lots of different areas, then often the doctor would then order one test, maybe the first test, that the most likely test, and that test would be done, and it would take 6 months, and the result would come back, and the clinician would pull the patient in and say, well, we haven't found a diagnosis, so let's do the second test. And this would carry on, and let's do the third and fourth test. And actually, in this way, I think there's some numbers. I think about 5 years ago, we were saying it was taking 2 or 3 years for patients to receive a diagnosis, but actually, most patients didn't receive a diagnosis in this way. So the new Genomic Medicine Service and the National Genomic Test Directory aims to provide comprehensive testing. So some of the technology that we have now allows us to do much more comprehensive testing than we did in the past, in a much more streamlined way, I would suggest. So once again, it's equity. This is about creating equity for patients. We're using cutting edge technologies, and we're regularly updating this test directory to add new tests, to look at new genes, to use new technologies, and to use new information to inform on those genetic tests. So why do we want to test somebody for a rare disease? And that might feel obvious, but often the patients, a treatment can be identified, a diagnosis that causes a treatment change can be identified, but sometimes not. But sometimes it's really important for a patient just to know what their genetic disorder is. It can also inform on the prognosis of somebody's disorder. But if you consider this patient as a child, then also having that information about that genetic diagnosis can help the family come to terms with that diagnosis. Often that information allows a family to reach out and find support groups, Facebook groups, and to be able to access perhaps experts and clinical trials where they hadn't been able to before because they didn't have that diagnosis or know what was wrong with their child. And genetic testing also allows for families to make decisions around their next pregnancies. So that's really important. So that's in this individual little family, but of course, in the wider family, there might be a cousin with the same clinical symptoms. And actually, if we know this patient's diagnosis, this genetic diagnosis, then we can test for that same genetic diagnosis in that patient. And we can inform on that patient's care also. And then one of the key things that we're trying to do in the NHS is to support data sharing. So in a secure and anonymized way, to be able to share information about genetic findings that we find in this family to inform on diagnoses in other families across England and across the world. So this is a really important part of testing for rare diseases, because this information can really help with diagnoses in patients. So I've told you why we do genetic testing for rare diseases, but how we do genetic testing for rare diseases. Well, I think in the same way that Patrick's told us about whole genome sequencing and a few other tests that we can do, for rare diseases, we have a huge toolbox of tests. So you can see we could do things like karyotypes, where we look at chromosomes, and we can do targeted sequencing, where we're looking at what is that one letter at that one particular point. Or we can do whole genome sequencing, where we can test thousands of genes at the same time. And we use specific tests to test for specific disorders, depending on the mechanism of those diseases or what we know about what causes those diseases. So there's a few other things in our genetics, in our genomics toolbox. And the first is our computers and informatics and bioinformatics. Our tools, but also our people are essential. So for informatics, we're running a lab where we're receiving samples all the time. We have to be able to track those samples. We have to do different things at multiple stages to those samples, and then we need to write a report with results to to send to the doctors to talk to the patients about their results. So there's a huge amount of informatics that goes along with these pipelines. And the same with the bioinformatics, especially when we're thinking about whole genome sequencing. We're generating huge amounts of genetic data, and our bioinformaticians and our bioinformatic pipelines have been built to analyze this data to provide our next and our key tool, information to analyze the data and to find a diagnostic result. So yeah, this is our third kind of key tool in the lab, our clinical scientists. And our clinical scientists are really key. They're professionally registered to analyze data and to send reports back to clinicians. And if anybody's interested in becoming a clinical scientist, please get in touch, because we're a limited commodity at the moment, and we need to encourage more people into this really important and really satisfying profession. So I'm going to give you a little bit of an example of two cases, but I'm going to first go through the pathway of how these cases were tested and how they were, how the genetic diagnosis was identified. So I'm going to talk a bit about rapid testing in pediatric patients. So in NICU and in PICU, so neonatal intensive care and pediatric intensive care, we have babies and children with very life-threatening conditions. And a rapid diagnosis can really change the management of those patients. And some of these patients will have genetic disorders, not all, but some. Often it's really difficult to diagnose, especially a NICU patient. You know, sometimes they're born early, there's no family history. Often genetic disorders manifest themselves as a child develops. And so some of these children are already have a very low weight, they're not fully formed. It's really hard to look at their facial structures to identify typical characteristics of disorders, because some of those features haven't developed yet. Some of our genetic disorders also have neurological symptoms, which of course you only really get to know when a child starts to develop and hitting those milestones. And of course, when a baby's born, and then especially if a baby's born early, then often biochemical and metabolic and hematological factors that you might normally measure in a 5-year-old child or an adult, they might be all over the place, you know. Being born is a tough thing, and being born early is a tough thing. So sometimes these levels of these factors aren't normal. So abnormal levels can be a bit of a red herring in these patients. So a genetic diagnosis can really help with these patients, because it can kind of cut through some of the lack of information from a clinical assessment of that child or that baby, and provide some information that might guide the clinicians who are looking after that patient. So often diagnoses can change treatment in this cohort of children. It can also perhaps allow for referrals to specialist services, and I've got an example of that. It can provide prognostic information for that child, and also, unfortunately, sometimes, but for the best interest of that patient and that child and that family, it can also allow for the redirection of treatments into palliative care. And for families, that genetic diagnosis can also help with decisions in the next pregnancies for that family. So this rapid, so Patrick's just told us about how important the rapid cancer pathway is, and it's really important in this pathway. We want a diagnosis as quick as we can to help that child or that baby. So what we do for this pathway is we sequence mom and dad and the child. So we get 3 blood samples and we extract DNA, and we send this to the Exeter lab right on the south coast, and they do rapid whole exome sequencing. So they're looking just at the exome, and the exome are the genes that we know that are associated with diseases in the genome. There's lots of bioinformatics, and our clinical scientists look at the data and generate reports and findings. And this all can happen in 8 to 10 days, which is great, which really informs treatment of these children. So I'm just going to tell you a little bit about how this analysis works. So when you look at genetic differences between a trio, we call this a trio, mum, dad, and the child, there are 20,000 genetic changes generally in an exome of these three. And I'm just showing you here the pedigree. So this is dad, who's unaffected because it's a clear box, mum who's unaffected, and this is our child that's affected. So, and there are 3 main reasons why a child would have a rare genetic disease. And so we can use that information, and I'll show you what those 3 reasons are in a minute. I'll use that information to screen down those 20,000 genetic changes into just a few that provides us with a diagnosis. So these are the 3 main reasons. So if you assume these are just genes, so this is dad with 2 normal genes, mum with 2 normal genes, and the child, the baby, has 1 copy of normal gene from dad, but he's got an abnormal copy of that gene. And we call this a de novo genetic variant. This is a new genetic variant that's happened in the first few stages after the egg and the sperm fused in this baby. So mum and dad are normal, and this is a brand new genetic variant that's causing that disease. If we think about another reason why these rare diseases can be caused, they could be recessive genetic variants. So mum and dad don't have the disorder, but they do carry 1 copy of the genetic change in a gene. And unfortunately, the baby receives 2 copies and so is affected by this disease. And then finally, there's another instance in babies that are born to mums that are carriers. So if you have X-linked genetic variants, so dad has 1 copy of an X chromosome and mum has 2 copies of an X chromosome, but one of her copies has a bad version of a gene, and actually the child then inherits that bad copy. And because he's a boy child, he's a male child, he only inherits that bad copy, and therefore he has a disorder. So when you screen those 20,000 genetic changes and just look for instances where these patterns occur, then you end up with a very short list of genetic variants that the clinical scientists will have to go through to try and identify the reason why the patient has the disease. So I'm going to quickly whiz, sorry, I realised the time. I'm going to quickly whiz through my 2 examples. So this first case is a 4-month-old in NICU and who had anemia. And when you have a look at their bone marrow staining, you can see that they've got these megablastic cells, and generally this is caused by the red blood cells. The precursors of red blood cells are larger than they should be, and this can be caused by a whole array of different things like leukemias, but in this case this patient was sequenced, and they identified recessive genetic variants in this gene. So mum had 1 copy, dad had 1 copy, and they passed both of the bad copies onto the child. And this gene is associated with a protein. This gene makes a protein that is associated with absorption of folate. And when the clinicians found out this result, they arranged for biochemical testing for vitamin B12, and then they were able to treat this baby with some folate, and some improvement was seen in their anemia. They also got that negative diagnosis of the fact that the baby didn't have leukemia, which was great news. And then very quickly, the case 2, we have a premature baby born at 26 weeks, and this baby ended up spending 14 weeks in NICU. And the clinicians suspected a rhizopathy, and a rhizopathy is a disorder that's caused by a number of genes. There's 20-ish genes, more than 20 genes known to be associated with these diseases that are involved in the regulation of the cell cycle. And in a young child, in a toddler, you can start to see the features of these disorders. You can see, you can measure the fact that there's some growth delay in these patients. They have dysmorphia in their facial features. They can have cardiac defects, but in a premature baby born at 26 weeks, that kind of information is really hard to see as a clinical diagnosis. So testing, mum, dad, and the child in this case identified a variant in one of these genes that does cause a rhizopathy, and this gene causes something called Costello syndrome. And it was really important to identify this because it meant that that child could then get referred to the cardiac team. And then because these disorders are associated with an increased risk of malignancies, then this child is continuously being screened. Oops, sorry, for this child is getting increased surveillance for malignancies. So I think very quickly I've shown you that rapid testing in children is really useful. We know that about 37% of patients that are going through this pathway are receiving a genetic diagnosis, which is really, really important. And we're getting a turnaround of results in 8 to 10 days. And so what's next is to try and transfer this technology and this bioinformatics analysis to all GLHs, all of the genomic laboratory hubs in the country, and to start to provide this using whole genome sequencing, so we can look at extended bits of the genome that might be important. So yeah, so sorry, I just rushed through those last few slides, but I think we've got some time for questions then. Thanks, Will.
Okay, thanks very much, Kate. No, great to hear from you guys. We are a little bit pushed for time now, but I think it was worth getting those presentations because they were tremendous. We have about 10 or 15 minutes left for questions. And I'd probably just like to bring in Dick and Gary next, because they've been patiently waiting through the call, but I'm sure they've got a lot to contribute on this anyway. Dick, I'd like to turn to you first of all with a very quick question. We've had a couple of examples there of how pediatric services might access these rare diseases. Can you give any other sort of clinical examples, particularly thinking about the patients who might be listening in on this call, about where they might interface with these genomic services?
Well, thanks very much for the question. I mean, often we use pediatrics and cancer as a sort of, if you like, the headline specialties when we're illustrating the huge impacts of all of the new technologies have had in delivering genomics. But genomics spreads right across almost every aspect of the NHS. And I'll certainly pick up a few examples of that, some which we might be familiar with, some which I think are just emerging. But there are a whole host of medical specialties that are routinely accessing or used to access what we would call genetic diagnostics that we now call genomic medicine. And adult neurology is a very, very big user of the service. There are many inherited adult neurological conditions. Cardiology as well. There are many conditions that affect both the heart and the aorta, for which a genetic or a genomic diagnosis is really key in one, providing diagnostic certainty, and then informing what the future follow-up plan would be for that individual and their family members. And this goes right across the spectrum. So a lot of referrals from hematology, another one of Kate's specialist areas, for example, my own area, renal medicine. So there are quite a number of inherited kidney conditions for which a genetic diagnosis will certainly inform whether or not treatment is required, whether the person will actually respond to that form of treatment. Genomics is also revolutionizing reproductive medicine, so allowing families to make fully informed choices about their choices in terms of having a children, for example. It's facilitated quite a number of new tests and investigations, from antenatal screening and also additional options when considering IVF treatments in what we call pre-implantation genetic diagnosis. And the list goes on. I think there are very, very few specialties that are not ultimately going to be impacted by genomics. And one I think is just hovering underneath the surface is something that we called pharmacogenomics. So that's looking at how we as individuals respond to different treatments, how effective those drugs are, and the risk of us potentially developing significant severe side effects. And we're just starting to see that emerge into clinical practice for 1 or 2 clinical indications. But I suspect that's going to become much more widespread as these technologies allow us to screen more genes in a larger number of people. So huge impact.
Great, thanks, Dick. Really wide-ranging answer to that. While we've been chatting, the Q&As just started to open up a little bit with a few of you putting in questions. And if you do have further questions, please don't hesitate to pop them in. I should have started this by saying I'm a governor of Adam Brooks Hospital, staff governor in my capacity as a cardiology registrar. And one of my fellow governors, David Deans, just put a question in, and he asked specifically about sequencing parents, whether this might discover potential diseases not related to the child's condition. And I guess that's a question actually that touches on not just pediatrics, but a lot of the screening we do. And I guess that you've just answered the question, so I'm just going to move over to Gary and see what his opinion is on this topic, because I guess, Gary, you must deal with this a lot, where you get cancer-causing mutations or potentially cancer-causing mutations picked up on screening, and how do you deal with that, and how do you deal with conveying those risks to patients and their families?
Thanks for the question. It's a really difficult topic. There are lots of ethical considerations here, and it's important to distinguish both whole genome sequencing and which necessarily needs a blood sample to look at the normal DNA within that patient to compare it with the cancer DNA to isolate those changes that are important in driving the cancer that Patrick very expertly alluded to. Now, with tumor-only sequencing, which is the bulk of what we do within the cancer service, that only can point to whether something might be an inherited predisposition to that cancer, with resultant implications both for that individual and potentially for other family members. It doesn't define that. With whole genome sequencing, if you do find a cancer predisposition gene in the normal DNA, then that does define it. So for whole genome sequencing, patients are consented up front for discussion of these potentially heritable variants, whereas for tumor-only sequencing, that doesn't happen. And if these are identified, it's then approached with the patient at that point. And many of these variants can be very difficult to interpret. So there may be key mutations that are there, and it's clear that this is a cancer predisposition variant. But for many variants within cancer causing genes that is potentially heritable, they may not be disease causing at all. So it's an incredibly complex topic, both from the scientific perspective and also from the ethical perspective. And as we sequence more and more patients, very close collaboration with our clinical genetics colleagues within oncology and surgery and other medical specialties will be key to make sure that the right information gets to the right patient who wants it at the right time.
Wow, thanks. You've tackled a very difficult field there in a very concise way. So well done. And certainly for me in cardiology, this is always a minefield, because we do send our heart failure patients increasingly for screening. Dick, do you have anything further to add to Gary's really comprehensive answer there?
Yes, just a couple of points. We are still learning a lot in this area, and as Gary says, it very much depends on the test. So a lot of what we're learning now comes from a very big project that many people may be familiar with called the 100,000 Genomes project, where very often we were, certainly in the rare disease arm, sequencing both parents of a child who had a genetic condition. And it was determined as part of that particular project that there were a small number of genes which, if they harbored significant genetic alterations, could be reported back, and those genes were clearly not related to the indication for the child being tested. And that very small number of genes were decided upon on the basis that knowledge of that genetic alteration would really provide clinical benefit to the parent to knowledge that. So that might be screening because of a high risk of breast cancer. It might be screening because of a high risk of heart disease, for example, in familial hypercholesterolemia. So there had to be an action or an intervention that would result from that. But we're still really sort of learning about the impact and implications of doing that study. So that type of approach at the moment really hasn't found its way into routine clinical practice. So at the moment, we're not really looking for those additional changes. We're only looking for the genes that we're testing in that particular individual, but that still occasionally may throw up some implications. So, you know, the example of the BRC genes has cropped up sometimes. You know, we know that an individual with one altered BRCA gene, you know, has an increased cancer predisposition, but we know if an individual who's got two altered BRCA genes in an infant, for example, has a very, very distinct and potentially serious clinical disease that's distinct from that. So in that situation, we may make a diagnosis in the child, which then has implications for the parents, for example, but that's very much an emerging thing. But the idea that we're routinely going to be finding lots of genetic variants that have implications for parents is not something that is currently practiced. So we're not routinely screening those parental DNA samples for genetic disease.
Right. Okay. Thanks there, Dick. And another very comprehensive answer. I appreciate we're just slightly running over time, but I know a few of you now have popped in questions, so we'll just try and rattle through a few of these and then we'll close up. There's one question on Facebook, which Kate, you might be best positioned to answer, but Dick, do feel free to come in. I've asked, how does this link with the bioresource?
So I used to work for the bioresource, so I link very closely with the bioresource. I think what we can consider is that the bioresources for rare diseases, it provides a research tool for clinicians and researchers to do clinical trials or to do gene discovery work or to do genetic studies in patients, either who already have a known disorder with a genetic diagnosis or in normal healthy people who might have genetic variants that are of interest. So we have slightly different job in the bioresource than we do for our clinical diagnostics, but a lot of it does feed in, and we're constantly having conversations with our colleagues in the NIHR, because we're doing very similar jobs. But yeah, I think very simply, it's the research side is the bioresource, it's the NIHR, and we're the clinical diagnostics route. But we do work very closely.
Great, thanks, Kate. I've got two slightly similar and linked questions. David Dean is asking, what's the cost of whole genome sequencing, and what capacity do we have for it? And also Emma McCorkle on Facebook's asking, how many patients are we roughly seeing regionally through the clinical genetics service? I don't know who wants to come in on those two questions.
Shall I answer the last one?
Yeah, I mean.
So our referral pattern across the east of England, we're a regional genetic services. I think it's running at about 6,000 referrals a year. So maybe not as many as cardiology, but.
I think I can answer the capacity question. So, well, our current capacity is building for whole. This was specifically about whole genome sequencing. I've got some slides in front of me from the central, from the genomics unit, and I can see that at the moment, all the GLHs put together are submitting about 300 patients a week, 300 samples a week for whole genome sequencing. So that might not necessarily mean 300 patients, because of course we're doing those trios and we're doing paired cancer and normal samples, but that's our current throughput, and we're working hard to increase that all the time. We've got a nice rise on the chart, yeah. And I don't know if Patrick has a better idea of the cost.
It's not really information we're privy to, is it, Kate? Because our cancer genomes are commissioned centrally, so the NHS will have a contract with our service provider, Illumina, and no doubt have a very competitive cost for Illumina to deliver those services. We know that there was always the sort of narrative that when is a $1,000 genome going to be available? It feels to me like genomes cost less than $1,000 now. And in some ways, I suspect they're comparable with the suite of sequential standard of care assays that one might perform in that currently replace the genome. And I guess in time, the hope is that the expertise and the logistics will improve such that a genome can replace some of those standard of care assays, and we can introduce financial efficiencies into the system via this most informative singular test.
Thanks, Patrick. Thanks all for answering this. But one final question, which is our last question is going to come from Jack. And he's asking, when it comes to genetic rare disease, are they usually present and identifiable from birth, or can they manifest later on in life, such as late teens or adulthood? And I guess I can speak to my specialty of heart failure here, Jack, where I know I have patients who've had a genetic mutation their whole life, but it's only in their 40s or even 60s that their heart has started to become weaker, stretched by the demands of life, and it's the pumping function of it starts to decline, resulting in them presenting with signs and symptoms of heart failure. So, and I think that goes to what Kate was saying earlier about rare diseases not being rare, and interestingly, a lot of very common disorders can actually have genetic predispositions. Dick, do you want to add anything to that answer from a lay simple plumbing doctor?
No, not at all. I think, as you say, rare disease we now know can present at any age, and we certainly see a lot of rare disease presenting in old age. So some of the what we call neurodegenerative diseases may not appear until old age. Clearly, there are sort of peaks at different age groups, and obviously a lot of genetic disease will appear in childhood, anywhere from the neonatal period all the way through childhood into the teen years. So there's a big peak of, if you like, genetic rare disease in childhood, but we certainly see, this huge range, as Kate sort of said, 6,000, 7,000, 8,000 sort of rare disease collectively becoming common. We see those appearing all the way throughout life. So it's not specific presentations at any one particular age.
No, and I suppose we have the issue that what are common conditions can sometimes have rare genetic causes, and
yes,
your service is being utilized to look for these. I did say that was the last question. One final question is just snuck in from Rafide Dasuki, who asks, Rafide, I assume you're a clinician, because you asked, would we as clinicians have access to the patient's genetic data registry in case of later complications or different disease presentations? And will we be able to go back and look at the whole genome sequence of this patient? I guess that sort of comes onto the access to this data. Who wants to come in on that?
Well, I guess I can come into that. So reanalysis of existing data is kind of almost what we're aiming for. We're aiming to provide cost effectiveness of genetic testing by sequencing a patient, and then we can use that information to diagnose that patient right at that time. But we might be able to go back in a few years' time if their symptoms develop, or we can test for more genes, or more genes are identified with that same disorder, or perhaps that patient has something totally new, and we want to then interrogate the DNA of that patient for a whole different disorder. So that's certainly possible. We're working hard. There's some challenges around information storage, LIMS, and but we're getting a lot better at that in the lab. Yeah, so that's certainly something that we're trying to be able to do.
I suppose this is another issue where we have patients who've been previously screened perhaps 20 years ago. Now we're thinking perhaps we should now be rescreening them as technology has advanced so much. Fantastic. I'm going to draw things to a close there, because it looks like we've run out of questions. But thanks everyone for sticking around for another 5 or 10 minutes. I think it was really worth it. Thanks again to Kate and Patrick for some really useful, interesting presentations that even someone like me, who it's a long time since I did the basic science of this, it was very accessible. So thank you. Thanks Dick and Gary for coming in and lending a bit of clinical relevance to all of this. But overall, thank you to our audience who've come along to listen to us tonight. Do please think about the work we do here in CUH, and think yourselves about if you're not already a member of the hospital, think about signing up and being a member. Think about becoming a governor like I do, and really getting a handle on the interesting processes inside the hospital. Fantastic. Thanks everyone for your time. I'll leave it all there. Cheerio. Bye for now.
Thank you. Bye-bye.
Bye. Bye.
Bye.